Hi, my name is Morgan Luff, and I'm presenting spatiotemporal research on obesity, a highly complex disease that extends to every region of the world. Obesity is defined as a disease characterized by excessive fat buildup, able to implicate other physiological functions, such as metabolism, mental health, and organ function. It is difficult to measure body fat directly due to variable anatomical and genetic differences. However, body mass index is the only accepted and standardized mean of measuring body fat for diagnosis. Obesity is highly complex due to interconnected factors that perpetuate its existence, and obesity as a whole has a significant social implication for today, as it can inhibit one from engaging with their community due to debilitating symptoms and secondary infections that may arise. Historically speaking, obesity emerged in industrialized nations due to abundant food supplies. However, obesity is rapidly growing in developing countries such as Libya. According to the World Health Organization, adolescent obesity is 30% higher in developing countries than developed. This inward trend suggests that obesity is a threat to the global community as a whole. Obesity is evident across the globe, irrespective of race, age, sex, and income level. 1 in 3 adults in the United States are considered obese, and this country accrues nearly $173 billion in obesity-related costs yearly, and this statistic is increasing due to a growing global population and ineffective mitigation strategies, such as attributing nutrition to personal choice only. Also, obesity is particularly alarming due to genetic predisposition, association between the maternal diet and child health outcomes, as well as racial disparities and inequities that are evident. Obesity can pose life-altering secondary infections that are able to decrease quality of life. On the left displays the distribution of self-reported obesity cases in the United States, with concentrations in the mid and southeast regions of the United States. The heaviest concentrations are in Kentucky and West Virginia, which can be indicative of sociodemographic factors that may explain why that is. Also on the right is the geographic expanse of obesity worldwide. To our knowledge, the United States is most threatened by this disease, and now developing countries in Europe, Asia, and Central Europe are at risk of obesity, especially among the youth, which we can observe in the concentration. The study used is the association between childhood obesity and the availability of food outlets in the local environment, a retrospective cross-sectional study conducted by the American Journal of Health Promotion by Dr. Miller, Joyce, Carter, and Young. The authors aim to explore the association between proximity to fast food and healthy food outlets and risk of obesity in children. The authors attempted to make the definitions of fast and healthy foods as all-encompassing as possible through prior research and statistics. Fast food outlets were designated based on their status as either national or international chains. Previous studies have considered only national chains, so this study attempted to improve the accuracy of the findings. Likewise, supermarkets, fresh fruit and vegetable stands, butchers, and general stores were considered healthy food outlets within this study. The authors considered factors within each vertex within the triangle of human ecology. The factors within the population and behavior vertices served as univariate control variables, allowing the authors to observe what makes children exposed or otherwise more at risk of obesity. These factors bridge the gap between geographic situation and obesity risk, as they answered the questions as why people are geographically situated in certain places and how their behaviors are modified by that. The population factors considered were socioeconomic status, sex, if the child was born in Australia, and the family structure category. The behavioral factors considered were time spent still or sedentary, the child's fruit and vegetable consumption, and physical activity in the prior week. The habitat factors considered were distance from healthy food outlet, distance from fast food outlet, number of healthy food outlets, which is thus the incidence and density, number of fast food outlets, and if the food outlet was accessible within an 800-meter or 3-kilometer distance using spatial buffering. The 800-meter represents the walkable distance from one's residence to a food outlet, and likewise a 3-kilometer distance represents a drivable distance to a food outlet from one's residence. And the authors determined these parameters based on studies that showed what is the likable distance of walking and driving that people will likely partake in order to access food. The authors of this study conducted a retrospective cross-sectional study design to identify an association between childhood obesity risk and proximity to fast and healthy food outlets. Cross-sectional study design entails gathering data on disease and exposure groups simultaneously. The authors attempted to study these associations in an area that has seldom been considered. The authors extrapolated data from the Western Australian Health and Wellbeing Surveillance System, a telephone survey, to gather socio-demographic information about the children studied and their parents. From this data, the authors were able to determine exposed and disease groups using ArcMap to measure accessibility and later achieve findings about the associations between these data sets. The study area is Metropolitan Perth, a city in Western Australia. There were 1,850 child participants in the study between the ages of 5 and 15. The authors gathered data on exposed, non-exposed, diseased, and not diseased through Western Australian health and well-being surveillance data. This surveillance system is a continuous data collection system, and the authors requested that parents, through a telephone interview, would provide data, and this allowed the authors to collect representative and qualified sample data. The parents provided information regarding their child's height and weight, which the authors used to compute BMIs. This determined which child was diseased or not diseased. Additionally, the parents provided information about the child's fruit and vegetable intake, socioeconomic status, family structure, and physical activity. Children considered diseased are those with BMIs classified as overweight or obese, and those not diseased are children with BMI scores below the benchmark of both of those parameters. Because obesity is a non-communicable disease, exposure is measured through proximity to both health and fast food outlets, and the authors explore the degree of exposure through the multivariate linear regression. The residences of the children were geocoded, which allowed the authors to assign socioeconomic indexes for areas, which is a score, as well as trace distance from those locations to food outlet locations. GIS permitted network analysis, allowing authors to assess spatial accessibility to food outlets. ArcMap was used to evaluate a child's accessibility and degree of accessibility to a fast and/or healthy food outlet. Specifically, the authors measured 1. The closest distances to both healthy food and fast food outlets using network distance. 2. If at least one health food outlet was accessible by car or foot, which is assessed by using 800-meter or 3-kilometer buffers. The 800-meter represented walkability, and 3-kilometer represented drivability, accounting for 2 food-seeking behaviors. The authors conducted multiple multivariate linear regression models to determine the associations between proximity to both health and fast food outlets and the risk of overweight and obesity status in children within the study area. The authors modeled density of each food outlet type. It is evident that fast food outlets are more prevalent in the study area as evidenced by the darker saturation of the map. The results of the study found that with an addition of one health food outlet, the risk of obesity of children studied decreased by 2%, showing that the density of health food outlets is associated with a decrease in obesity risk. A similar trend was observed in fast food outlet prevalence. However, there was little significance when adjusted with health food outlet modeling. As evidenced by the table and the results of the study, the distance to closest health food and fast food outlets are the reference variables with odds ratios of 1. From the results of the study, we can infer that access to at least one health food outlet within an 800-meter distance is associated with a 0.38, so an 80 or a 38% decrease in the risk of being overweight or obese compared to those with no health food outlet within an 800-meter distance. And this is found by subtracting 1, the reference variable, by 0.62, or the independent variable that we are examining. Likewise, for every additional percentage of health food outlets within the distance, the risk of a child being overweight or obese is decreased by 1, and this is found here, with an odds ratio of 0.992. It is evident that all of the odds ratios for all of the different parameters are below 1, so that would warrant a negative relationship. And though a fast food restaurant intuitively would warrant a greater increase in obesity risk, we can attribute this to confounding variables and other factors that may influence this trend. Here are the results from a univariate logistic regression result from the control variables, which warranted the various socio-demographic factors that were examined, allowing the authors to infer causality between certain characteristics, as well as food-seeking behaviors that may perpetuate or prevent obesity risk. To expound on the previously stated statistic, there was a strong negative association between the number of health food outlets or proximity to health food outlets and the risk of obesity or overweight designation. An addition of one health food outlet warranted a decrease of overweight and obesity risk by 19%, but this statistical significance is not observed within a 3-kilometer distance, which we can infer that an immediate environment around the child is most deterministic of their food behaviors. Additionally, the inverse relationship that we observe between the fast food proximity and decrease in chance of obesity risk is surprising, but can be attributed to confounding variables between health food outlet proximity and fast food health proximity, as they are both dependent on one another due to market competition and the built environment. The limitations of this study are embedded within the lack of complexity that is cross-sectional design, as both exposure and disease groups are simultaneously gathered through prior data. Also, accessibility to these different health food outlets are categorized and pinpointed through latitude and longitude, and not accounting for food behaviors outside of this parameter. For example, children can access foods from friends, from family, and from secondary sources, and not from those locations. Also, a health or a fast food outlet may be designated as a different location based on level of healthy food, depending on the study. So the study may not have encapsulated all of the fast food or healthy food outlets within the study area.